the bispecific antibodies are clearly off-the-shelf products. So you can actually go to the pharmacy, you can get a precise dosing, you can choose between subcutaneous IV application, you can decide between different application modes, and even further, you can decide about the target. Now, with the CAR T cells, you have to take what you get because the CAR T cell product is highly variable. It depends on the T cell subset at the time of leukapheresis. It depends on transduction efficacy and also viability of the CAR T cells. Furthermore, it can take up to 8 weeks from leukapheresis to CAR T cell infusion. So it's definitely not an off-the-shelf product with a high variability. I think these are clearly advantages for bispecific antibodies. Now we are moving into allo CARs, which probably will help us to get the CAR T cells more as an off-the-shelf product, but I think there's still issues about immunogenicity, extensive genetic engineering, which might also have an impact on the persistence and the function of the CAR T cells. Now, if we look at the, so CAR T cells are kind of, one expects that CAR T cells is a one-shot treatment, but in myeloma, the persistence is rather limited. And so at the moment, a lot of strategies are involving CAR T cells plus additional drugs like IMiDs, CELMoDs, immune checkpoint blockers, anti-CD38 antibodies, or tyrosine kinase inhibitors to actually improve the persistence of the CAR T cells. So for me, for myeloma, the CAR T cells are not a one-shot treatment. Now, the BiTEs are kind of considered as an ongoing treatment forever. But here I feel that with the BiTEs, and we have experiences and also from different trials, we know that probably giving BiTEs for a short time period will already induce a maximal response. So I don't think that we really need to give BiTEs until progression. And furthermore, there's the issue of retreatment. And I think with the CAR T cells, at least with the BCMA-directed CAR T cells, we have some experience that retreatment is not really very effective. In contrast, at least with BiTEs, in other disease settings like B-ALL, we know that we can retreat the patient very successfully. So I think there are quite a few arguments in favor of bispecific antibodies when compared to CAR T cells. Now, going to the efficacy and toxicity, what we know is that the overall response rate and the complete remission rate is higher with CAR T cells. So with CAR T cells, it's overall response rate 80 to 100%, CR rate 40 to 85%, and with bispecifics, the overall response rate is slightly above 60%, and the complete remission rate between 30 and 50%. Also, the progression-free survival that was reported seems to be longer for the CAR T cells. But on the other hand, the toxicity is higher with CAR T cells, more severe cytokine release syndrome, more severe ICANS, and more hematotoxicity and more infections with CAR T cells when compared to bispecific antibodies. And I think the BiTEs are still in kind of dose escalation phase. So maybe also the treatment efficacy will improve with the bispecifics. And last but not least, the elderly patient, there are data that you can treat patients even beyond 80 with bispecific antibodies, which probably is not feasible with CAR T cells.